welcome to the Might Ramble podcast.
Ron, tell us about that.
Not 2, not 3, not 4, not 5.
Now I am become death, the destroyer of worlds.
From this distant vantage point, the Earth might not seem of any particular interest.
Hello, everyone. Before we begin, the views expressed in this podcast are our personal views and do not reflect those of any employer, university, research institution, funding body, or collaborator. Participation by guests does not imply endorsement of my views, nor does my hosting imply endorsement of theirs. Okay, that's all. Today, my guest is Dr. Carla Sharp. I don't think she needs an introduction, but perhaps we'll get to that here at some point. Okay. Carla Sharp is a professor here at the University of Houston. I believe you're the director of the Developmental Psychopathology.
I am, yes.
I don't know if it's an institute or a lab.
No, it's just a lab. Yes. Me and my students, yes.
Yeah. And then prior to the University of Houston, your journey began in South Africa.
Yes,
you did your undergrad there.
Yes.
Then you went far away to Cambridge,
yes.
I think in the UK.
That's right.
You did a PhD.
Yes.
And then after the PhD, you probably postdoc based on my understanding of academia, but then you ended up at Baylor.
Yeah, Baylor College of Medicine for my assistant professorship. Yes.
So we've had South Africa, we've had the UK, and then we've had the US.
Yes.
And then I think you were at Baylor in the early 2000s,
yeah.
And then you transitioned to the University of Houston maybe in 2008?
2009.
2009?
Yeah, 2009, yes.
Nice, right after the Great Recession, or maybe perhaps right in the midst of it, the US.
Yeah.
So that is how Carla ended up here today.
Yes.
And Carla, would you be able to explain a little bit about what the focus of your studies has primarily been?
Yes. So thank you for that introduction and thank you for having me on your podcast. I'm very happy to be speaking with you, but also your listeners and viewers. So, my focus, I would say, is probably twofold. Firstly, it's on the concept of mentalization or mentalizing. I've always been interested, it's a social cognitive construct, so I've always been interested in social cognition. And what social cognition is just our capacity to make sense of ourselves and our social world. And our social world can be defined as very broad, like society. That's not what I'm working on. But it can also be a little closer to home. So our interpersonal relationships, our attachment relationships, the relationships that matter to us. So I've always been interested in the fact that people can be in relationships, that they can have relationships with each other, the power of relationships, both good and bad, to help you through your life, but also to make your life hard. And then not only the relational component, but also what undergirds it, which is your capacity to make sense of self and others. So that's what mentalizing is, our capacity to make sense of ourselves and other people in our attachment relationships. So that's my one focus. And then my other focus is, how does this go wrong for some people? And there's a lot of things that can disrupt that capacity. It can be our personalities. So I'm interested in personality disorder, but there can also be things that happen to us. So if we have particular life events, or we have a lot of stress, or we have trauma, all kinds of things can disrupt our capacity to make sense of self and others in our relationships, with knock-on effects. And so I'm interested in this capacity, mentalization capacity, how it plays out in our relationships, how it can go wrong in relationships with a focus on personality disorder a lot, and then how can we intervene early so that if you did grow up in a context where disruption takes place, how can we help you to get back on track so that you can have a fulfilling relationship life?
Sure. Yeah, as far as personality disorders, if someone does get off track and you have the ability to intervene early, the amount of future suffering that can be prevented both, for the person with the personality disorder and for those around them is immense in terms of how that would play out over a lifetime.
It is.
And for those unfamiliar with borderline personality disorder, which I think has been a particular area of focus for you, just to state the gravity of what this condition can be, I think it's estimated something like 40 to 80% of people with borderline personality disorder have attempted suicide.
Yes.
10% complete suicide.
Yes.
The far majority of them, one of the hallmarks of someone with BPD is that they probably attempted self-mutilation of some sort, as far as like cutting and stuff like that. And BPD is, a serious condition, and I think we're in the midst of a transition here as far as, do we want to keep, borderline personality disorder around as like a term or phrase we use in concept, or is it better fitted to more underlying central aspects of personality pathology?
Yes.
For someone that is unfamiliar with borderline personality disorder, maybe they've heard of it, but it's kind of this mysterious thing, you don't really understand it. Could you walk us through just kind of the basics of borderline personality disorder and how we currently think about it in the DSM?
Yes, I'm happy to do that. So really, since the 1980s, we have defined borderline personality disorder with, broadly speaking, 9 criteria. And this is in the DSM, and remember how the DSM works. The DSM lists a bunch of criteria, and then if you meet a certain number of those criteria, you meet criteria for the disorder. And the DSM sees psychiatric conditions very much like medical conditions. So you have it or you don't have it. You've got cancer or you don't have cancer, or you've got diabetes or you don't have diabetes. And so for BPD, the 9 criteria are, and I hope I remember all of them, but anger problems, affective instability, so mood lability, suicide and self-harm, impulsivity, emptiness, feelings of paranoia, often stress-induced or mistrust, dissociation, that goes with that. And then abandonment fears, which is really central, in my view, to BPD. And then relationship problems. I think I hit all 9. I didn't count. I should have counted.
It was either 8 or 9.
I think did I? Identity problems. Oh my
word. There we go. Yeah.
Identity problems is probably, in my view, the central issue. And I'll get to that. So BPD always, since the 1980s, you've defined it with these sort of 9 criteria, and if you meet 5 of those criteria, then you would be considered someone with BPD. Now, we've learned a lot of things about that in the last 20, 30 years. Number one is that the suffering that people have when they have 3 criteria or 4 criteria can be as much as someone with 5 criteria, 6 criteria, 7 or 8 or 9. So
in the way that we diagnose BPD, you have to meet 5 of the 9 criteria.
You have to meet 5 of the 9. And so the first thing we discovered is that that's kind of arbitrary, because in actual fact, people can have real sort of challenges if they only have 3 criteria met, but because they don't meet full criteria, they don't get treatment. The insurance company wouldn't pay at 3. So we learned that actually we need to have more of a dimensional view of how BPD manifests itself in terms of its severity, rather than saying yes, no. And we know that actually for all psychiatric illnesses, all psychiatric conditions should be placed on a dimension, and we should be able to give treatment to people at lower severity levels. So that's one important thing that we learned. The other important thing that we learned is that it's very difficult to find people that fit the BPD box precisely. What typically happens in practice is that if someone has meet criteria for BPD, they also meet criteria for other personality disorders. So they would meet criteria, there's in the DSM 10 personality disorders. Often people with BPD would also meet criteria or would have traits, 3 or 4 traits maybe of narcissistic personality disorder, antisocial, maybe obsessive compulsive disorder. Maybe it manifests itself more avoidant, and they'll meet criteria for avoidant. Maybe it manifests with a more paranoid type flavor, and then people will meet criteria for BPD and paranoid personality disorder. So we've had always people, especially if you use structured assessment, people will meet criteria for more than one personality disorder. On top of that, they'll meet criteria for depression and anxiety and PTSD and substance use as well. And the moment you get, you go to the doctor and the doctor says you have cancer, but you have cancer and diabetes and heart disease, it begins to call into question that particular disorder, because it seems like the boundaries are porous and it seems like the boundaries are not well defined for the disorder. And so that's the second thing that happened in the literature. And so the third thing that happened is that because it's called personality disorder, there was this idea that this person is now in this category. They've got BPD, and that's how they are as a person. And we've learned that that's not actually the case. It functions very much like depression and anxiety, that people move in and out of clinical thresholds through their lives, and that it really is not who they are as a person. It is much more than that. It's like a condition that they're trying to manage. Yeah, and so I think that the word personality got people a little confused as to how it manifests. It's not as intractable and stable as people used to think it is. And we discovered this through data, longitudinal follow-up studies.
Just to interject a little bit. So what you're saying is that BPD, the way that we think about it is if someone has a BPD label, that it's this static thing, and they are like this all the time, right?
They are not.
And what you're saying is that the data has shown is that it's actually much more fluid. They move kind of in and out of this condition, similar to someone going through, say, waves of depression.
That's right.
Let's say they always got postpartum after having children, right?
Exactly.
They move in and out of depression.
Exactly.
And as far as are they BPD or are they a person with BPD?
Right.
It brings to mind on my end a little bit. I'm someone that has struggled with addiction historically, like substance abuse, right?
Yes.
And coming to terms with, I am not my addicted self. I am this separate self that has had this condition.
Absolutely, absolutely.
And although that's not my fault, it is my responsibility, right, to figure out how to best manage that so it's not bringing harm to me or others.
Yes.
I am curious, you mentioned that the lack of internal identity for someone that's been diagnosed with BPD, that you view this as perhaps the central feature of BPD.
I do.
I have read, conversely, that the fear of abandonment is the central tenet, I guess, of the BPD construct. And so I'm curious about that.
They are tightly related to each other. What we are talking about actually is self and interpersonal. So we're talking about this very intricate relationship between self and interpersonal functioning. And it's no accident that, in my view, but also in the alternative model for personality disorder, and we can get into the alternative model and why we have an alternative model, but in the alternative model for personality disorder, so this is an alternative way of diagnosing BPD or all personality
within
disorder.
the DSM.
Talking about the DSM, So in the DSM, there's section 2 where you will find the 10 categorically defined personality disorders, the yes or no approach. And then in section 3 of the DSM, you will find the alternative model. And it's in a chapter called Conditions for Further Study. And there's a long story, and if you want to get into why we have the two, we can get into that. But for now, for the alternative model, we diagnose personality disorder by assessing self and interpersonal functioning as the main entry criterion for it.
How do you assess something like that? Because when I think about this, like as a person trained in chemistry with some biological experience, like I think tangible, objective, like can I get down to like molecules and genes and very hard data, whereas this is something more external facing and less perhaps as firm of grounding as something like finding a particular molecule.
Right. I wish we could do a blood test or a scan, but you can't do that for any psychiatric condition, right? So So we assess it like we assess all psychiatric conditions, which is we ask people about their internal experience. When it's depression, we ask about mood and, you know, your interest in things and how lethargic you feel and demotivated. For personality disorder, we ask, how do you manage yourself in situations? How do you feel? Can you hold on to yourself? Do you have a stable sense of identity? Does this change a lot? Do you feel like you are sand through your own fingers and you can't grab a hold of yourself in certain situations? Do you have a stable self-esteem? Can you go in and kind of recover quickly if you get bad news in terms of yourself? Or do you stay and ruminate and put yourself down? So that's on the self side. Relationship side, how do you get on with people? How do you manage your relationships? Do you feel you understand other people well? Or do you find yourself kind of confused and disappointed a lot because someone you didn't get why, and you back to square one in the same pattern and you don't know how do you get yourself back to the same pattern? Is it a struggle for you to get on with people, both at work but also in your personal relationship? And then how do you understand yourself? Just do you feel you've got a good sense, and can you forgive yourself? Can you have compassion with yourself? Can you make sense of yourself and other people? So we assess all of those aspects for self and interpersonal functioning. Now, coming back to those 2 criteria in the DSM section 2, the 9 criteria. So there are really, you know, different views on personality pathology and personality functioning. I am on the side of thinking that the self function drives the interpersonal function. Other people think the interpersonal function drives the self function, or they may not even give priority to self function in that conceptualization. They really just see it as interpersonal patterns.
In the canonical book, I Hate You, Don't Leave Me, as they list the first criterion for potentially being diagnosed with borderline personality disorder, it's that fear of abandonment one, and then it says, others act upon me, therefore I am. Yes.
I do think everybody with personality disorder, regardless of the flavor, have a sense that things happen to them, rather than that they take agency and that they're the captain of their own ship. I think that's a shared feature for everybody with personality disorder, whether it's BPD, antisocial, narcissistic, OCPD, whatever the flavor.
Like cross-cluster.
Yeah, it's a cross-diagnostic feature, that there's a sense of that life happens to me and not that I can take ownership of, and that for me lies in the domain of the self-function. The reason I prioritize self-function is because when we look developmentally at how personality develops, we don't really, and develop how personality disorder develop, we don't really feel confident in diagnosing personality disorder until adolescence. And the reason for that is that until adolescence, you know, we can see individual differences in children as small as 2, 3, 4, 5, 6 in how they get on with people. Some people are introverted, some people are more emotional, some people get into more tangles, little toddlers get into, they lie on a continuum of how well they get on with other children. We can define that. The thing that we can't define until we get to adolescence fully is self-function. We cannot say, you know, when there is a little 7-year-old that is struggling with a peer, we don't say that 7-year-old has problem in his or her self-function, that they have identity issues, or that they don't manage themselves well, because we don't expect of a 7-year-old with their level of brain function to have that kind of regulatory capacity. But when we get to adolescence, we expect 2 things. We expect that beginning in adolescence, and you solidify this to age 25, that you are able to begin to have some self-regulatory capacity. You can step outside yourself, see yourself from the outside in, and begin to say, okay, hang on, let me slow down here. I don't think I need to have this need. I don't have to just act out upon the world. I can begin to regulate how I want to be perceived.
Think about how I fit into this. How do I want to fit into this?
How do I? Who am I in this? So that relates to the second piece, is our identity formation. So we are beginning to make decisions almost intentionally about, this is me, this is not me, this is me, this is not me. This is the people I want to hang out with. These are the people I don't want to hang out with. This is what I want to expose. This is what I want to dress like. This is the kind of music that I want to listen to. So I prioritize self because until self is coming online developmentally, we can't diagnose personality disorder. So to me, my logic then says self must be key to personality disorder, because otherwise I could diagnose personality disorder. If personality disorder was just interpersonal function, I could diagnose it in a 3-year-old. But nobody feels comfortable doing that, because I think intuitively we feel that there is an identity, self and identity piece to personality, and we have to wait till that comes online to see if it's healthy or not.
It's like we have to wait until it's like buffering, right? And video is loading,
Yes.
and then we have to wait until the video is at a certain point to be able to make a judgment.
Yeah. And so coming back to your question, how do we assess for it? We do ask questions about self and interpersonal functioning for sure, but more importantly than that, when I ask the question, I am going to look not only at the content of your answer, but how you answer it. If you are able to relatively succinctly and with a sense of authenticity tell me the answers to these questions, I'm going to be more convinced that you don't have personality disorder. If we take double the time for you to answer these questions because you go off in long tangents and you kind of get confused and you explain things to me in a way that I'm also getting confused, and maybe there's discrepancy between what you said 10 minutes ago and what you're saying now. If there's those discrepancies, I'm going to say, okay, I don't get that there's an integrated sense of self here. I don't get the sense that this person has had the time, capacity to really make sense of, and they will run into trouble, because if they get into a particular situation with a certain person, they don't feel like there's a rudder inside that can steer them through it. And they're going to feel much more anxious, and they may say stuff or do stuff that get them into trouble. So it's not only the content of the answer then for self and interpersonal functioning, but the process by which you and I begin to understand each other.
Sure. Like consistency temporally.
Yeah.
As far as what they're saying, and then lining up, say, 15 minutes later, 2 days later, et cetera, et cetera.
So if we think about depression, I can ask you depression questions, and you can answer them affirmatively, and I'll diagnose you with depression. But I may not even ask you personality questions, but the way that you answered the depression questions may start helping me think, ooh, I'm not sure where your personality functioning lies. You may have personality difficulties on top of the depression that you have. But not because of the questions that I asked you, but because of the dance that we were dancing and my sense of confusion, mounting confusion as we entered into the dance. Yes.
As a psychologist once told me, you're easy to read, Mitchell. But so this personality functioning that you're referring to, is this, okay, so it's something like IQ, right? If someone has an 100 IQ, we would say they're of general intelligence. Now within that 100, one person that has 100 and another person that has 100, they may be very different. There are flavors within there. Maybe one's good at math, but not great at reading, and the other's very good at reading others, but not good at math, right? But they would score the same if you were to boil it all down to that one number, right? Below that 100 is less, right? Less than general intelligence, and above would be more than general intelligence, right? So this personality functioning, is this the descriptor for when you boil it down to one number as far as self-other functioning?
Yeah. So well done. You've done your reading and you're a good student. That is exactly it. And I love that you used the metaphor of IQ. If we get into the math of this, we've determined through factor analysis that's exactly that personality functions the same way as intelligence, that people lie on maybe a bell curve. We don't yet know fully the function in the general population.
And this is based on factor analysis of, let's say, someone doing an assessment, right? And the person answering questions, scoring that quantitatively along a scale, and then
reducing it to its core features. You know, the least number of of variables that explain the covariation.
Yep.
So all those items correlate with each other. But can we pull them down into one
regress
thing?
them
them into one thing that explains all the covariation, or do we need three different things to explain it? And we've discovered we need one thing, which is self and interpersonal functioning. It also turns out, coming back to a point we made earlier, that self and interpersonal functioning are highly correlated with each other. So, and we can go back to psychoanalytic theories, Kernberg's theory, object relations, Melanie Klein. Of course, Erik Erikson, of course, how I relate to myself is going to impact how I relate to others and vice versa. So the two are very, very inextricably linked with each other. But we have done this sort of factor analytic work. We have determined that there is this unidimensional severity criterion that is defined by self and interpersonal functioning. And that, we don't yet know if it's got a bell curve. We don't yet know, like IQ, that I think it does. I think there are people in the middle, and most of us are sort of in the middle. None of us are superhuman beings who are always regulated and always able to be good with people, and always, none of us are. I'm not, for sure. So, I have met some people that have impressed me in the level of personality functioning range, where I'm like, oh my God, this person is amazing, right? They just never seem to lose their cool. They always seem to be integrated. But honestly, it's few and far between. Most of us, I think, lie in this sort of middle place. And then there are some people that struggle more on the bottom end of this. So, I think this concept of personality is much more destigmatized for this reason, that we can all sign up for this idea that we've got a personality, that we can all sign up for the idea that we have to manage it, that we have to manage ourselves and interpersonal functioning, that it's not easy for anybody. I have a boss too. I have several bosses. I have kids. I have a husband. I have friends that I have neighbors that I get into tangles with. And I feel ashamed by my pettiness, if I didn't keep my cool in a particular situation. So all of us have to take ownership of this. It's not just people with personality disorder that need to take ownership of and here I'm going to introduce another term. I like to talk about the serve and return. All of us have to take ownership. That dance, we have to take ownership for the serve and return. I can't just go through life serving and leaving it to other people to catch my balls or hit my balls back. I have to take ownership in how I'm going to serve it so that it's understood at the other end.
Yep.
And I think that's what people with personality disorder struggle with. They don't always, in the moment, have the capacity to serve it in a way that it gets understood as they intended. And they misunderstood. They go through life being misunderstood. People get angry at them kind of wrongly, because for most people with personality disorder, they did not intend to hit the ball in that way. They just got overwhelmed in the moment, hit the ball in a particular way, and it landed out of the court or in the wrong place, and now they're in a tangle and they can't get back onto the court, or they can't get out of the game, So they get themselves into tangles. Most people with personality disorder don't intentionally go about messing up their relationships. They don't. It's a misunderstanding if people out there think they do. People get hurt. I don't want to minimize that. I do think people do get hurt in relationships with people with personality disorder, and the anger is justified. It's not that we say everybody with a personality disorder get a free pass, but it's a bit more complicated than that. People assume intentionality in the serve and return, and often it wasn't intended. It was just not fully having the capacity to slow down and think about it from the outside in.
Yeah, I struggle with a little bit, where do we balance, compassion for a disorder, and while also communicating, I think, the severity of harm that can result to both them and others as a result of being very unmanaged, right? And I won't share too much about my personal experience there, but I am someone that, I ended up with some form of PTSD as a result of tangling closely with someone that exhibited some of these characteristics, right? And so, finding that line, I guess can be difficult.
Yeah, I totally agree with you. And especially if we begin to look at antisocial features, we now think about this sort of unidimensional severity criterion as maladaptive self and interpersonal function as your entry criterion, and then it can manifest in different ways. And I would say in that manifestation, you can get more harmful and less harmful flavors.
Yeah.
Some people with personality disorder are going to be more intentional in how they hurt other people than other people. So for a whole group of people, that damage that they do is unintentional. They get overwhelmed, they can't think in the moment, and they hurt another person. And then there is a subgroup of people, and I would put people with narcissism, strong narcissistic features in that group, and I would put people with strong antisocial or psychopathic features in that group. They are people who will more intentionally hurt others. Now, I would still say, so I would put, my bar for compassion moves when I'm working with this group, but I do want to just invite your audience to also think even about those people as that, I'm not a big believer in evil. I don't think the intention to harm another person comes out of some evil force.
I think it's very, very rare in life
very, very
that
rare.
you actually run into like genuine, what I would consider evil.
So even that group of people who actually sits and plan how to hurt someone, and they exist, absolutely. That comes from somewhere. That comes from the serve and return they experienced at an earlier stage in their development. Yeah. And so as a psychotherapist, I have to have compassion for them because otherwise I can't do my work. As a recipient of their malicious behavior towards me, I will not have compassion because that is not fair for me to be a victim of whatever intentional harm they are doing to me. So, but as a psychotherapist, I have to have compassion.
Yeah, and I think anger, when I really think about anger is a deep form of care, right, in a way. I really care about...
Tell me more about that, yes.
Anger as a deep form of care?
Yes.
You're only angry in situations where either you really care about someone and like how they're behaving and how that's affected you, or something happens that, I guess anger in the form of anything to deal with other people is some type of deep care. Yeah. Even if a stranger violated you in some way, it's this deep form of care of some societal rule or expectation or culturally of others that has been violated, some form of sacredness, right?
Yes.
And so in that way, I think anger really is a deep form of care. Yeah. And, it's a primitive part of ourselves, sure, but it's also it's a powerful force, right?
It is powerful force.
There are going to be times in our life when we find ourselves angry.
Absolutely.
And I want to distinguish anger from perhaps frustration, right?
Yes.
I mean, like genuine
anger. Yeah.
I've been hurt type of thing.
Yeah.
Yeah, and I think it's our responsibility in life to figure out in those times that we are angry, how do I get this channeled in a constructive direction, right? Because it can be a powerful force. You don't want to live out of anger forever, right? But it can be a pretty good impetus to make some changes. Yeah. And I also think in this idea that anger is a form of a deep form of care.
Well, we were talking about compassion and where that line is drawn, and I was saying as a therapist, I have to have compassion with even the most deviant of individuals, but as a victim of someone's malicious acts, you certainly do not have to have compassion. Now, the compassion researchers and the forgiveness researchers will tell us, that it's often in a person's best interest to overcome the anger or overcome the hurt. But that's a different story, that's not the personality disorder. So although I would say that I think most people with personality disorder have attachment trauma in their histories. And that's difficult, so I often get the question about PTSD and BPD or complex PTSD.
I was going to ask you, where does trauma and PTSD end and something like a personality disorder begin?
It's a very, very good question, a question that everybody struggles with. So I would say that most people with personality disorder that I have come across, worked with, assessed, have a history of attachment trauma, and that means that in their experience of their close relationships, they did not feel safe, heard, understood, and mirrored. And that, importantly, the caregiver environment, in most cases, did not intend for that to happen either. There may have been a temperament misfit. People who end up having personality disorder, we know this from research, have a sensitive temperament, and that is not bad. Most of our important leaders have a sensitive temperament. Most of our important artists have a sensitive. Most of our novelists have sensitive. I would say a lot of professors have a sensitive. Intellectuals.
Deep form of care.
Yes, another deep form. So there's nothing wrong with being emotional or reactive or feeling things deeply. In fact, it's essential that we have people that can do that. The problem is if that is matched with a parent who, for some reason, at that moment in time, cannot meet a sensitive temperament. And the message that the kid gets is, there's something wrong with me. I'm defective for feeling these things. And the moment a young person begins to feel I'm defective, they begin to develop a sense of self that's either incoherent or negative, or begins to evoke that from the environment in order to confirm that they're negative or defective or wrong. And a vicious cycle begins, and these patterns get, set in stone.
Hard-coded, yeah.
They get hard-coded, and it's very difficult to break them. So my point is just that everybody with BPD and with personality disorder that I've worked with have a sense of attachment trauma. It may not look like PTSD. It may not look like a sexual abuse, physical abuse, but it was a internal experience of not being seen, heard, understood, or loved unconditionally.
And we don't typically think of those types of wounds as really physical, but they are. The way that a body reacts,
they can be.
Right.
Yeah.
Things are produced or expressed differently or developed differently as a result of having felt that way, right? And I do remember what I was going to say about anger.
Yes.
Anger is a very normal emotion to feel.
Yes,
I think
it is.
a lot of times we, try to be above, actually feeling anger, and we try to dismiss it from ourselves and not let ourselves feel it fully. But I think it is really important. If you're angry, you have to feel it, and you kind of have to let it burn through you. When the time comes, when you've kind of processed some of that anger, like the antidote to that is understanding, right?
Yes.
The more I understand why this happened, or how this happened, or what the person that did this to me, why they were that way, right? The less angry I am, more compassion.
Coming back to mentalization, making sense of self and others, so hard. And I mean, there's, I always say to my patients or anybody I work with and the students that I supervise in their psychotherapy, we kind of just shoot for 6 out of 10. We don't try to be super mentalizers. It's not attainable. You can't be a 10 out of 10 mentalizer. Thinking about those superhuman beings again that in their personality functioning are amazing. I don't think it's attainable. And I think we can't always hold ourselves to the bar of always understanding others and always forgiving and being compassionate. It's not possible. But we have to cut ourselves some slack at times and give ourselves time to get an understanding, right? Some people, it'll take longer to forgive than others. But if we continue to work towards understanding, forgiveness, compassion, you have a better chance of having a meaningful and joyful life than being consumed by the anger, resentment, disappointment, and hurt. Yeah.
Thank you. One thing I'm curious about, so I think BPD once upon a time was thought as maybe a deficit in mentalization.
Yes. It was sort of, I mean, that the whole mentalizing story. So in the beginning, Peter Fonagy wrote a very seminal paper in 1991 where he, for the first time, put out this idea that BPD may be a problem in mentalizing, a problem of making sense of self and other.
And what we mean by that is perhaps that people would act in ways that you might think on the surface, how could they do that and not think of me, right?
Exactly. Yeah, what they we think about autistic people as mind blind, that they cannot think what other people are thinking. And people with BPD can come across like that. What were they like, How could you? Why would you say that, Or often with BPD, it is like, no, that's not what I was thinking. So that's what we learned very quickly with BPD, is that rather than hypo-mentalizing, under-mentalizing, in other words, like autistic individuals, a lot of people with BPD and personality disorder hyper-mentalize. They overthink what you are thinking. So, and they, another word for it could be projection. They project actually what's in their minds onto your mind.
It is shocking the way that their, say, fear of abandonment or some issue they're going through, how they actually make that become a reality.
Yes,
right?
yes. And if we come back to the core features, self and interpersonal functioning, there is a problem in the boundary between where I end and you begin.
Yeah.
So there's a merging of self and other, and a confusion of self and other. And if we rewind back to attachment and we think about where does this come from, we're thinking about someone with a very sensitive temperament, trying to look for cues from mom or dad or nanny or older sister of who am I, me, not me, and they're not getting the cues. So they're constantly hypervigilant, mind reading, trying to find themselves in the mind of the other, and the information's not forthcoming.
I kind of think of it like, take the Bible, for example.
Yes.
The Bible has what is written in it, and then there are people who are trying to find some secret code in the Bible.
Well, that is an interesting analogy. Maybe overthinking what's in the Bible. That's an interesting thought. So yeah, I think people with personality disorder have had to work very hard in their attachment relationships to try and find who I am in the mind of the other person, because it wasn't forthcoming, or even worse, something came back that really was not true, which is very confusing if you think about it. So, and that is often the case in where there's real abusive situations, where emotional abuse, sexual abuse, there's a message that's coming through that is completely discrepant with the internal experience. So this is highly confusing. So fast forward into adult relationships for these individuals, there is a merging of self and other, and a merging of minds, and what the psychotherapy needs to do, and that's what we do in mentalization-based therapy, is really slow down and try and tease out, okay, well, hang on, was this in your mind, or was it in his mind? You know, what made you think that was what he was thinking?
Or did you think it was in his mind?
Yeah, or do you think it was in his mind? Can we begin to tease out? Can we get closer to what you were feeling and access that, and then think, what was he feeling in that moment? Can we rewind? Can we change the serve and return? So it's essential that happens in any psychotherapy for personality disorder, because that's our unit of focus, is the serve and return. So the work we do is actually not going back. So coming back to trauma, I'm not a fan of trauma work. We're not denying the trauma. The trauma was there. We are asking how the trauma and early experience showed up last week. How does it show up last week? What was that serve and return where the footprints of that trauma is showing itself? And we are trying to change this going forward. That's a much more hopeful, manageable goal for therapy than trying to process something that we redefine every time we talk about it. You can talk about what happened 20 years ago for hours and hours and years without getting resolution, because of the way our memory works. Our memory will put a new spin on it every time we talk about it. So in MBT, we really stay in the here and now, and we go forward and we say, how does what happened in the past show up at the moment? And can we begin to change the serve and return? That's a hopeful, manageable, feasible thing to do.
Yeah, and I think there are some perspectives on trauma, if a trauma is severe enough, where you're never really given, or I guess if you get a very serious professional opinion, they may tell you that this is a wound that may never fully heal, type of thing, right?
Yes, and I don't think they do heal, really. I think we learn to live with them, you know.
Kind of like scars is how I think of it.
It is. That's a good metaphor. I think because we can't turn back the clock, we can't undo, we can't change other people either. I can't, just because I worked through the trauma and understand why my mom did this, that won't change the relationship with my mom magically. Yeah. What will change the relationship with my mom is serving the ball differently at my mom today, and seeing how that can come back in a way that's manageable for me. So I like our focus in MBT on the here and now, and moving forward, and really using the serve and return as the focus of our work.
Sure. So coming back just a little bit, we talked a little bit about, I think it's Peter Fonagy and mentalization type of theory, and thinking that BPD might be a deficit in mentalization, hypomentalization. And we now view it more as something that is hyper-mentalization, right? Where you're taking in too much information given the actual context, right? You're thinking way too much about this little thing,
overthinking it,
And then there was also, I think you were heavily involved in BPD becoming diagnosable amongst adolescents. And so I wanted to just hear a little bit about that story and how, I don't know if fighting for it is the right word.
It is. I do feel like an advocate for it now. I'm not a very radical militant advocate, but I am an advocate in my own way.
I would say you're a radical in a way that, say this BPD being a central, maybe being a core latent structure of personality pathology in general, doing that work, right? But then also being involved in, maybe we need to shift BPD into something that's dimensional rather than these 9 tenets, right?
And the two are related to each other. The fact that we need to think dimensionally about things, and dimensional, I'll just quickly do a bit of a lecture, means two things. It means it lies on a continuum of severity, as we discussed before, but it also means that there are underlying dimensions that explains the covariation. So we can reduce a lot of different problems down to its essential features. That's also a dimension. What's the structure, and that is a dimension. It's because it is continuous in nature. It's not categorical. So dimensions have two meanings, but the two are connected in my mind, the dimensional and the developmental pieces, because when we make a construct dimensional, we can begin to intervene earlier in its progression. So if we think about how personality develops and how personality disorder develop, we can identify much earlier on that severity spectrum when problems begin to emerge in self and interpersonal functioning. So, I've got an 11-year-old and I've got an 18-year-old. So I've got the two bookends of this process. And my little one is just beginning to do me, not me, me, not me. My 18-year-old has a big chunk of me already worked out.
It's so interesting too how it aligns with, say, like a neurobiological development timeline, synaptic pruning, right in adolescence.
Thank you for saying that, because that's exactly it. That's the work of adolescence. It's a use it or lose it thing. So if I'm going to use thinking about myself, making sense of who I am, if I'm going to use checking in with my mom, how are things going, what should I be doing, and I'm getting a ball back that I can manage, those synapses are gonna get stronger. I'm gonna be better at self and interpersonal functioning.
It's just like if you train a particular muscle at the gym, right? It's going to get stronger.
But a lot of teens don't get that. They already didn't get it, as we talked about the little kids. They already didn't get it in the serve and return early on. They were sensitive. They started getting messages that made them feel insecure about who they are. Now they're in adolescence where all of this pruning and, specializing needs to take place.
Yeah, need this, don't need that, right?
And it's still not happening. In fact, I saw with my 18-year-old, you have to be much more vigilant as a parent of a teen to keep the serve and return going, because they actually opt out of that relationship. They're not interested in parents anymore. Yeah. They're interested in their peers. So what I say to parents is be available on their terms. So with my 18-year-old, when she's ready to talk, I stopped everything. I dropped everything and said, okay, tell me more about it, because this is the minute I'm going to get. If I say to her, I'm busy right now with work, I'll get back to you tonight. By tonight, it's over. I can say that to my 10-year-old, my 9-year-old, my 8-year-old, but you cannot say that to a teenager. It's gone. So you have to be available at the time that they're ready for the serve and return. Why do I want to do the serve and return with her? Because I want to practice that muscle with her in a benign way, in non-intrusive, helpful way.
Yep.
So this is the work of adolescence. This is when we want to help adolescents get this capacity for self and interpersonal management. If they don't get that, then we're going to see personality disorder. And, my journey to this was almost an accident. I was at the Menninger Clinic at the time, and we started doing assessments in the inpatient unit. And we discovered.
When was this?
This was 2004 to, well, actually, no, that's not when we started. No, when did we start? We started really 2009 to 2016. We collected all this data on young people on the unit, more than 800 kids in the end. And we discovered that personality disorder look very similar in young people than in adults. Why? Because it is when adult-like self and interpersonal functioning come online. And that was a surprise to me. I was with a lot of people thinking we shouldn't be diagnosing before 18. I was like a lot of people thinking young people don't have a personality yet. Turns out they do have a personality, and turns out it's very plastic. And this is the time that we need to intervene. And I became an advocate for early intervention and prevention alongside several other people. Andrew Channon was one of the leaders in the field. Perry Hoffman from the National Education Alliance for BPD at the time brought a lot of experts together. We put out a position statement, and we've been trying to get people to feel more comfortable with early diagnosis and prevention treatment. The problem we've been running into is people worry about stigmatization.
Oh yeah, there's a saying,
yes,
right, for like say a doctor or a therapist,
yes,
is like you're one BPD client away from losing your license, right?
I hate that people say that. Yeah. I think that is so stigmatizing to say that.
Oh, incredibly.
Yes,
yeah.
And because what I try to teach my students is that with your general training in psychiatry and clinical psychology, you can treat people with personality disorder. There's nothing to be scared of. Why? Because it lies on a continuum. There are loads of people in our environments with personality disorder that we don't even know they have personality disorder, but they are bad at self and interpersonal relationships.
Maybe approximately, I should say roughly like 10% might be close to cluster B proportion in the population.
Well, actually, some prevalent studies puts it much higher. You
really?
know, up to 17%. Yeah, some prevalent studies, depending on how you measure it, puts it up to. But even, and that's thinking about who meets criteria. There are people with personality difficulties among us all the time.
Right.
You know,
the 3 out of 9.
A coworker that is difficult to work with. Someone. I mean, so it's not. I think a much better approach to this is to say that there's nothing special about personality disorder. That it doesn't need to be put on this pedestal as a dangerous, awful, intractable, non-treatable thing that's going to lose you your license.
Be, but probably most of them are not like that.
In few circumstances. I think Marsha Linehan did us such a service when she developed a treatment approach where a borderline patient can call you. Imagine that. You know, there was this idea, they cannot have your number because they cannot know where you live because they'll come and burn a bunny on your oven stove.
I've read a lot of stories,
Glenn Close, you know, in Fatal Attraction. The Glenn Close character is a minority of people with personality disorder. Most of the people with personality disorder just have problem in the serve and return, and they need help in order to navigate that. So I was grateful to Marsha Linehan for saying, you know, you can. I don't get called by people with BPD. They can understand that I have a life, that I go on vacation, that I have children, that I need to, you know. So it's a terrible disservice when clinicians, and actually I will just say this, studies show that the stigmatization of BPD is unfortunately carried forward more by clinicians than the general public. It is clinicians. So, and I'm trying to mentalize that. I'm trying to understand that. It may be to do with some feeling of being overwhelmed. Maybe we don't give enough training to clinicians so that they feel overwhelmed.
It's also probably a bias of some sort in the sense that I have a clinician who told me at one point, I said I'm reading about the neurobiology of something like borderline personality disorder. And I think the common notion is there's probably not much there. We don't really know, right? And the phrase I got back is some people just suck, right? And I think coming back to addiction, right?
Yeah.
If someone's an addict, It doesn't mean they're a bad person.
Right.
It lies on a continuum. There are people that have been addicts that have incredibly good character.
Yes.
And there are people
Yes.
that
course.
are actually malevolent,
course.
right, and have bad character.
And there are people with
They just have this
personality
condition.
disorder. There
Yeah.
are people with personality disorder that intentionally harms others, and there are people with personality disorder that don't intentionally harm others. So, you know, it comes back to this idea of personality. You know, people think because they somehow choose to be like that. 50% of our personalities are genetic. Those are the trait pieces. That's our temperament that we inherit from our parents. And, you know, then those temperamental traits interact with the environment, and they either get attenuated or they get amplified, depending on the help we get. So, you know, to parents who have a kiddo who's emotional, intense, or reactive, that parent needs a lot more help in the serve and return so that we can begin to manage those intense temperamental traits rather than amplify them and develop a sense of self that's defective, wrong, and I could just do harm because people hate me anyway.
Right.
Yeah.
Yeah. A lot of different threads here we could go down.
Yes.
Let's say. So one thing I want to address is if we were to list out the 9 criterion of BPD in the DSM.
Yes.
I think all of us in some way will identify with parts of it, right? But how do you differentiate? Yeah. Where's the stratification here in terms of being able to look at that list and being like, I do identify with that versus an actual diagnosable personality disorder?
You know, I think it comes down to frequency and intensity. So if I am angry most of the time or have anger outbursts most of the time and they're intense, I break stuff, I hit stuff, I scream at people. If I have mood lability to the extent that it's almost every day and it exhausts me and I feel like I'm all over the place, and if I have abandonment fears to the point that I'm going to text people all the time, make sure, put on tabs, if I'm going to have self-harm or suicidal ideation that it kind of overwhelms me, if I have identity issues, so frequency and intensity is one thing. And then the other thing that I think people can look at is how much does whatever you feel you identify with a little bit interfere with your life, mess up your life. You know, I am an emotional person. I feel things deeply. Oh, I can cry watching a movie. I love that I can feel I've got a daughter who dances. I love that I can be moved by art, by her dancing, or by dance that I see on a stage. I love that music can move me, but does it interfere with my life to the point where I am a victim or, I can't manage because my emotions are all over the place? So to what extent does it interfere with your interpersonal relationships? To what extent does it interfere with your life? That's where I would draw the line between this is just someone who's emotional versus someone who, has a problem and needs therapy to deal with it.
Thank you.
Yes.
Another thing, let's say you do have BPD and you very much consider yourself, someone that hypermentalizes, is over-assessing different situations.
Yes.
What do?
You slow down. Anybody listening that has problems in these domains, yes, so how do we slow down? So the core of mentalization-based therapy is that we, if I had a pill that I can give someone to just, they're in the moment and just press the pause button and say, it's time to take stock. I usually say to patients, try and think about a sort of internal thermometer, that you have a thermometer of any bad or negative emotion. Maybe it's anger, maybe it's sadness, maybe it's feeling overwhelmed, maybe it's anxiety, maybe it's a feeling of stress, whatever the emotion is that could trigger you. Know where your level is, that if it hits 6 out of 10, maybe it's 8 out of 10, you need to press the pause button and remove yourself from the situation. Take a moment. Excuse me, I need to go to the restroom. I'll be right back.
Yeah.
Hang on. Take a moment, gather yourself. And I say those words with intention, gather yourself. Because remember, people with personality disorder, their selves disperses. When they have a lot of stress, they feel overwhelmed, the self disperses. They need to gather themselves. Go take a moment, gather yourself. When I work with little kids, we have a puppet that has it's a turtle, and the turtle goes into the shell. Go into a cocoon, go find yourself. Go gather yourself and rewind what was happening. What was he saying? What was he doing? Where was I? Why was this triggering me? What was the problem? Yes. Rewind that and get in touch with yourself and then think, okay, how do I want to go back out?
Yeah.
How do I want to go back out? Yes.
One thing that people who have been diagnosed with BPD tend to struggle with is object constancy.
Yes.
Right? I'm sure this ties back to kind of a fluid,
insecure attachment.
Fluid self. And in very severe forms, it'll be you're in a conversation.
Yes.
And they've said one thing at one point, and then later on, they're like, I never did that type of thing.
Yeah.
Right? And they literally cannot understand that their actual reality and understanding of it has shifted.
Yes.
Right?
Yes.
And so I'm curious, this also ties into there's several things I'm curious about here. This idea of splitting.
Yes.
Right?
Yes.
Where a typical BPD relationship that becomes intimate in some way, whether it's emotional, physical, etc., it goes through this cycle where it tends to be idealization. Sometimes people call that like love bombing the person, right? And then you start going through this cycle of idealization, devaluation, idealization, devaluation, and it becomes, there's this fear of abandonment, but if the person gets too far, they got to get closer, right? It's like they can't keep the person at the right distance. And so for the person on the other end, there's this push-pull that develops.
It's very difficult,
Right? Push-pull that develops in the relationship. I think psychologically you refer to it as intermittent reinforcement. But then at the end of the relationship, it tends to be, can be quite explosive, is what I would say. And although at times you still may see shades of being idealized, right? That you are perfect, you can do anything, you'll save me type of thing. It'll go from that to this is the worst person ever, they've always been wronging me type of thing. And so I wanted to get your take on like what goes on when someone splits.
When someone splits, we have a concept in mentalization-based theory and the therapy called psychic equivalence. Psychic equivalence means, psychic equivalence is one of three what we call non-mentalizing modes or pre-mentalizing modes. Psychic equivalence means that when you're in the moment, whatever is in your mind, you believe is true. So the reason we call it a pre-mentalizing mode is that it's actually normative in some areas of development. So like for toddlers, I think about my little one who was, she had an Elsa dress from Frozen, and she had a big Elsa doll. And when she put on this Elsa dress, and she was with the Elsa doll, she became Elsa.
She is Elsa.
She is Elsa. It is almost psychotic in that, that's how little kids play. They become. Now, psychic equivalence is like that. For the person with BPD, in that moment, what's in their mind is true. They cannot see an alternative perspective in that moment. And so part of the work that we do in MBT is to begin to know when you are in psychic equivalence. Usually you are in psychic equivalence when you're emotional. So you should really press the pause button and go back, gather yourself if you've got BPD, because when you feel very strongly, when you feel certain. That's the psychic equivalence is 10 out of 10 certainty. Certainty is not your friend in personality disorder. If you've got a tendency to have personality disorder or personality problems, guard against certainty. Always try and bring down your certainty from 10 out of 10 to 6 out of 10. Because we never know. We never really have the full facts. And your go-to is clarification. So if you feel certain, you are in psychic equivalence, you've stepped out to calm down, to gather yourself, then you go back in and ask for clarification. May I ask what I heard? Is that what you meant, or did I get this wrong?
Have you ever seen Memento?
No, I have not.
I think it's one of Christopher Nolan's early films.
Yes.
And it's a strange film, but it's this guy, every day when he wakes up, he can't remember anything about the past.
Yes.
And so he has to put these reminders all over the walls and himself to be like, oh, this is like who I am and what I'm trying to figure out. And I guess I've never had that internal experience of splitting to that, I've seen it, right, where it's like they are sure of their reality right now.
That's right.
Absolutely sure. But I it's really interesting, that idea of opposite action.
Remember where borderline comes from, the term
Psychosis.
border between neurosis and psychosis. So that certainty, a real psychotic person is certain that they're seeing an image which doesn't exist. That's the most extreme form of psychic equivalence. Delusion, hallucination is the most extreme form of psychic equivalence. People with BPD don't have that in a full-blown way, but I would say people with severe BPD can actually edge to that psychotic place. So it is very hard for a person with personality disorder in that moment to bring down the certainty, but that's the work that they need to do. They need to get, because I come back to values too. So if a relationship is important for you, then it behooves you to press the pause button, leave, gather yourself, and come back, clarify, and see if you can move that certainty down from 10 out of 10 to 6 out of 10, because otherwise that relationship will end.
Yeah. Very interesting. Another thread I want to pull on a little bit is, what is your understanding of, I guess, where we sit currently as far as differences in like the brains of people that have been diagnosed with personality disorders like this?
We have a lot of information, so the people, the naysayers who say, people choose and it's not, it's not brain-based. It's definitely brain-based, like everything else. The problem with the brain correlates that we have is that it's not specific to personality disorder. People with depression have some of the same problems. People with anxiety have some of the same problems. So in none of the neurobiology, that's why people have, people struggle with finding neurobiological correlates for any psychiatric condition that's specific to that condition. So I think it's probably much broader than that. So we've started in psychopathology research. We look at common factors that so for instance, we can choose something like executive functioning. Everybody with psychiatric difficulties have executive functioning difficulties, and we can find clear brain correlates for executive functioning difficulties. Everybody with psychiatric difficulties, including BPD, have emotion regulation problems, so we can find neurobiological correlates for emotion regulation problems. So I would say we've got neurobiological correlates, but when we start looking at psychopathology more broadly, it's not specific to personality disorder, and it's these broad dimensions that associate with psychopathology more generally.
What's the latent
underlying
structures here? Interesting.
Now, I would say, I think we keep learning, right, and we keep getting better at accessing the brain. I would be very interested going forward to see if our technology allows us to get a bit better at understanding the brain correlates of self and interpersonal functioning. We don't really have great brain correlates for that. People got very excited about oxytocin. They thought maybe people with personality disorder or all the attachment-related problems, we have, but it turns out that was not so helpful either. So I am interested in thinking about what are the brain correlates of an incoherent self. We have no idea of what that looks like. You're making sense of but I think it may be that we never can get there because it's connectivity rather than
you're also approaching
location.
The idea of where's the root of consciousness here?
Yes, exactly.
So,
yes, you're absolutely
the hard
right.
problem of consciousness, right?
Exactly. I think that's where personality lives. Personality lives in this place where we make sense of, it's the reflective capacity, and that's what makes it different.
What is it to be, right?
What is it to be, and to move through the world with agency and with intention. Those are the hardest philosophical difficulties and the hardest neurobiological difficulties.
We're getting closer, but I don't know. I don't know if it's a code that can be cracked. I guess we will see. Every episode, I've been having the previous guests write a question to the next guest.
Yes.
So I was wondering if you could open up that, and you will find a purple sheet inside.
Yes.
And the question is from Maria Esaza.
Yes.
And
Okay, let's see. And who is she?
Maria Esaza?
Yeah.
She is a pretty well-known jiu-jitsu fighter in Austin.
Okay.
Originally from Colombia.
Yes.
And Yeah, has a pretty vibrant, thoughtful personality. Yeah.
Okay. So her question to me is, what is your why? What is my why? So I guess that question relates to what drives me. And I think what drives me is the desire to understand. You know, I think I've been so surprised at things in life that what has driven me is to try and understand, you know, not only people's behavior. I do remember when I was an undergraduate, I was like, there was this epiphany moment where I needed to decide what I'm going to study. And I was like, I want to understand the mind, you know, I want to understand, you know, why people do the things that they do. You know, so because I am fascinated, I'm constantly surprised by what people do. I'm constantly surprised by, you know, what family members do. You know, my daughters, I would be like, they're so different. I'm surprised by what my husband does sometimes. I'm surprised that I still, after 25 years of marriage, can't predict what he'll do, or that I don't understand why he's responding in a particular way. I am surprised by what politicians do. I am surprised by what my students do. So, you know, I think I'm driven by, you know, constantly being surprised and trying to understand what motivates people, and I guess linked to that, how people suffer. You know, I think people suffer a great deal, and can we help people relieve some of that suffering? So, yeah.
Nice.
Yeah.
Thank you.
Yes. Thank you. That made me quite emotional thinking about that.